part. So starting by the refractive procedures, we have the LASIK procedure. So the LASIK procedure is a procedure in which we are cutting a flap and invert this flap in order to do excimer laser ablation to a corneal stroma to correct the refractive error. So we can correct the myopia, hypermetropia, and astigmatism by this way. So this is a kind of corneal refractive procedure. How it is done? First of all, the cornea is marked before cut. Then the surgeon will create a corneal flap. This will be like by the help of a device called the microkeratome. This will cause creation of the flap with a hinge, and then the surgeon will flip or will elevate this flap in order to allow the laser to ablate the stroma. This flap can be created either manually by the microkeratome. This is like a surgical blade, or it can be created by femtosecond laser. Then the third step will be ablation by laser, and then we reposit the flap again and make sure that this flap will be covering the whole cornea and it will be centered in it well positioned with no stria, and then the surgery will be completed. So this will be maybe the standard procedure for corneal refractive surgery right now. Another previous operation was called the epi-LASIK. So the epi-LASIK, let's see what will be the concept of the epi-LASIK. In the epi-LASIK, we are placing a suction ring. So a suction ring will make the cornea steady. So it will be like fixing the cornea. And then by an epithelium separator, this is like a blade, an epithelial separator will move across this suction ring to create a very thin tissue, very thin flap. So then the separator will leave one end of the epithelium intact, and which will act as a hinge and will create a flap. So this is another way to create the flap. Then remove the suction ring and then pull the epithelium to a side gently, do the ablation and deposit the flap. So it is just another way in order for apart from LASIK, it is another way in order to create a flap. It's called the epi-LASIK. A third refractive procedure is called the PRK, or photorefractive keratectomy. So this was the older generation of the refractive surgery, of the corneal refractive surgery, which wasn't utilizing any blades or any microkeratomes or no flap creation. So this is a flapless procedure. So how it is done, we are doing the anesthesia by anesthetic drops. Then we are removing the epithelium. There are many ways to remove the epithelium. There is what's called hockey knife, and this will be by the help of alcohol. So we are putting, some surgeons prefer to put alcohol. This alcohol, like a drop or 2 drops of alcohol, will be helpful to loosen the epithelium, making the scraping of the epithelium easier. And for now, new machines can do what's called trans-PRK, in which we are do ablation of the epithelium by laser, then followed by the PRK itself. So whatever the methods for removing of the epithelium, this will be, it will end up by removing of the epithelium with whatever instrument, then doing the laser. So here we are doing the laser, doing ablation of the stroma without creating of the flap. So no flap to remove, no flap to reposit, just doing ablation. And with the help of the PRK, the problem is that we are ablating the Bowman's layer. So the Bowman's layer, as you know from the basic sciences, that it will heal by scar formation. So the abnormal keratocytes and the ablation of the Bowman's may result in the patients will be complicated by haze, post-operative haze. So this will be the main problem for the PRK. And in order to minimize this problem, we use what's called mitomycin. Again, the mitomycin has a role here to minimize the keratocytes proliferation and the haze formation. After doing that, we are actually, after doing the PRK, we are creating to the patient an artificial ulcer. So we removed his epithelium. So we put a bandage soft contact lens in order to protect the eye as the epithelium is healing. So it usually should take a few days for the healing to occur. and then the patient's refractive error will be restored or will be corrected. Another procedure for refractive surgery is called the LASIK. And in the LASIK, it is called the laser epithelial keratomileusis. And in this case, we are putting like a cup over the cornea and putting alcohol, a drop of alcohol, the same way we are doing the PRK. However, we are not removing the epithelium as in PRK, but we are just taking it to a side. We loosen the epithelium by the alcohol. Then by this spatula, we are just putting the epithelium on a side, doing the ablation, laser ablation, then reposit the epithelium again. So this will like be another way to do the LASIK procedure by creating a flap, but with the help of alcohol, but it is not very popular. So what are the popular surgeries that are being done in the current practice or in the modern era? It will be mainly the PRK and the LASIK. Every one of them has its indications and contraindications, or let's say there are advantages or disadvantages. So let's say if a patient is going to do a PRK or LASIK, what will be the advantages or disadvantages of each one of them? For the PRK, first of all, it is the advantage that it is easy technique. So actually the human factor here is very minimal. Like the surgeon interference is very minimal. So no need for skills for this procedure. And also it is more safe because there is no flap related complications. The flap itself can have wide range of complications like deep lamellar keratitis, like the presence of stria, like presence of uncut or cut flap, or what's called, this happened with me like last week, Dr. Muhammad, you know, that I had a patient for LASIK and he had suction loss during the LASIK, and the flap was incompletely cut. So this doesn't happen with the PRK. Less ectasia, so the PRK will be more favorable for the biomechanics of the cornea. So less incidence of PRK for less incidence of ectasia after PRK. Less cost because the patient shouldn't take or shouldn't incur the cost of the microkeratome and the blades. They will be more helpful or more safe for patients who can be liable for trauma, like patients who can be are sportsmen, or those patients in the military. So if a patient is liable to trauma, this can cause dislocation of the LASIK flap. So PRK will be much safer for them, and less incidence of dry eye. So one of the commonest complications after refractive procedure, of after corneal refractive procedure, will be the dry eye. So this dry eye will be less in the PRK than in LASIK. So these are the advantages of PRK. What are the advantages of LASIK? LASIK will cause a faster rehabilitation, so the patient will restore his visual acuity very rapidly. However, in the PRK, they will take more days, like a few weeks, in order for both of them will reach the final visual outcome, the same final visual outcome after 1 month. But it is just the faster rehabilitation in LASIK, but less rapid rehabilitation and more changing refraction after PRK. And of course that the LASIK will have less pain because the PRK, you are creating an ulcer for the patient. So PRK will be more painful. So these are the advantages. What are the disadvantages? In the PRK, the problem of persistent epithelial defect, or you are creating an ulcer. So this epithelium could be delayed in healing. So this especially with patients who are, or when we use alcohol, or when the alcohol reaches the stem cells. So remember why we are using this cup, in order to minimize alcohol reaching the stem cells, as this will delay the epithelium healing. Another option or another complications for PRK is the infection. Actually, you removed the barrier. The epithelium is acting as a barrier to prevent the infection. So more incidence of infection. PRK is famous for its regression in refraction. So it is very common that those patients will have recurrence of their refractive error, especially for hypermetropia. For patient of hyperopia, for most of practitioners, they don't use PRK for hyperopia correction because of the high incidence of regression. Slower rehabilitation, as we mentioned, and scar formation, what we call the post-operative haze. Post-operative haze can occur, which doesn't occur with LASIK, but occur only with the PRK, resulting in diminution of vision. So how do we prevent or minimize the post-operative haze formation? This is by the use of mitomycin, and also by good patient selection. So for those patients who tend to develop scars or keloids, especially those who are dark-skinned, they are more liable to develop post-operative haze. Fourth are the complications of LASIK. As I mentioned, there are long list of flap complications. As I told you, the stria, the incomplete cut, the buttonhole, the free cap, the deep lamellar keratitis, all these can occur with the flap. Affection of suction on the posterior segment, like what would the suction that we are applying for the LASIK, this will raise the intraocular pressure up to even 100 millimeter mercury. So if a patient is glaucomatous or having optic nerve damage, this rise of the intraocular pressure by LASIK can cause damage to the optic disc. Also may induce retinal detachment if there is breaks, but here a safer option will be the femto-LASIK, will be a safer option for those patients. LASIK will be associated with more dry eye as you are cutting the corneal nerves, and also will be associated with more ectasia because it will cause more disturbance to corneal biomechanics. So to summarize, what will be the decision making for a patient with refractive patients? For patients with low to moderate myopia, like -1 to -4.5, excimer laser will be the option, like LASIK or PRK, which is called surface ablation. For high myopia, between -4.75 to -10 diopter, excimer laser or LASIK or advanced surface ablation, but here there are precautions. First of all, the corneal depth. The second of all will be that for corneal depth will be very important, that it will allow ablation of this, but for most practitioners, they will not exceed -8 diopters for excimer laser ablation. Also, another concern for the PRK, it will be that the more the ablation, the more the incidence of haze. So again, this is something that you don't want. But for some cases, if you are more concerned about the patient safety or the corneal thickness doesn't permit, you can do refractive lens exchange, especially if the patient is after 40 years. So you do the refractive lens exchange after 40 years of age. As before 40 years of age, there are higher incidence of pseudophakic retinal detachment. So what do we do if the patient is less than 40 years? We do exchange or phakic intraocular lens. So we can implant a phakic intraocular lens like implantable collamer lens or ICL. This will be helpful to correct the refractive error. For the extreme myopia over -10, it is reported in the literature that the excimer laser can do up to -12 diopters, but this is not advisable. So again, this is not advisable to do this high refractive error. The best is to do just a refractive lens exchange or phakic implant. For low hyperopia, +1 to +3 diopters, excimer laser can be an option, but please notice that there is two problems. In the LASIK, if you are doing LASIK, the better to do a femto-LASIK in order to do laser on the periphery. So by femto-LASIK, you can create a larger flap, which will not be possible with the LASIK. So you need to ablate the periphery to correct the hyperopia, and this will be possible with the femto-LASIK. This is the concern for LASIK. For advanced surface ablation or the PRK, the concern here is the regression, as I mentioned. So again, some papers say that they can do it for hyperopia with no incidence of regression, but it depends on every surgeon's experience. For some cases, we can do possible refractive lens exchange, but for this low hyperopia, this is unusual. For moderate hyperopia, again, excimer lens or refractive lens exchange for like up to +6. According to literature, +6 is the maximum limit for hyperopic correction for excimer laser. Like the highest limit for myopic correction is -12. So for hyperopia, our limitations are much less for hyperopia than in myopia. It will be up to +6. We can do excimer laser or refractive lens exchange. Extreme myopia or extreme hyperopia, like +6 diopters, this will not fit into any corneal refractive surgery. It will be just will be for the refractive lens exchange, nothing more. Okay. Okay, Dr. Islam, might Weiss do under correction? No. No, there is no under correction here. Mayo ring in high myopia have a rule? Yes, a Mayo ring can be used for high myopia, but this is out of the scope of the exam. Okay, finally, the last part will be the just a brief about the pentacam or the brief about corneal topography, so that if you are presented a corneal topography map in the real exam, you would know how to interpret it. So this will be more likely for the ICU exams. It was presented earlier, but in the FRCS2, it is unlikely. Okay. So the pentacam will be having the famous map is called the refractive 4-map display. In this map, consists of many boxes. There is a box for patient data and the exam data. So the first thing to look is the patient's age. So you know what will be the age of patients, especially for keratoconus patients and also for refractive patients. Then there are data for the anterior corneal surface, like the K readings, the K1, the K2, the K mean, the astigmatism, and the axis of the astigmatism. And similar data for the posterior corneal surface, a box for corneal thickness and thinnest location, other box for pupil diameter, anterior chamber depth, and the intraocular pressure, especially for, we would check it for the anterior chamber depth for patients who are going to do refractive lens, do the phakic IOL. Then we have 4 squares or 4 maps. The first one called the sagittal curvature map, then the frontal elevation map or anterior elevation map, then the back elevation maps, and the pachymetry map. So these are the maps of the refractive 4 maps display. Let's analyze each one of them. What will be the suspicious signs that when you see, you consider a patient could be at high risk of developing or having keratoconus? For the curvature map, the normal of the curvature map, that it will represent how much every point of the cornea is curved. So if it is very curved, it will represent it by hot colors like red and orange. If it is less curved, it will be represented by cold colors like green and blue. So for this, what we can see, there is an increased curvature in this meridian and taking the form of what's called the bow tie. So this bow tie has 2 segments, upper and lower segment. So this patient has with the rule astigmatism because the vertical meridian here at 90 degrees is more steep. And these 2 bow ties are almost identical in size. So this patient has regular with the rule astigmatism. So this will be the normal, vertically symmetrical bow tie, mirror image. The highest refractive error or the refractive meridian will be between 43 to 44 diopters. It will be steep more temporal. This is the temporal and this is the nasal. It will be steep more temporal than nasal and more lower than the upper. That's why the keratoconus is an exaggeration of the normal. It will becoming the keratoconus, there is steepening more temporal and more lower. So this is the normal curvature maps. This is how a patient with keratoconus with map will look like. Here, the patient has hot spot. You can see that there is no symmetrical bow tie. There is hot spot inferiorly. The K max or the maximum Q reading is more than 47.2. You see here it is 62.8. This is 57.5. So when the K max, the highest Q reading is more than 47.2, this is considered suspicious for keratoconus. For different topographic patterns of the curvature map, it can be rounded, which means that the patient has spherical error only, oval, which also means that the patient has it has a spherical error, or it can be with a superior steepening, which means that the hotness or the hot area is present superior, which we unlikely to be keratoconus. It more can be due to scar or suture. So examine the patient, because this is not typical for keratoconus. Inferior steepening, which is very suspicious for keratoconus, is the picture that I showed you right now. This is inferior steepness. Irregular pattern, which can be due to either keratoconus or due to scars in the cornea. So there is no identifiable pattern. Symmetrical bow tie, vertically symmetrical bow tie, as you can see here, like the first image, which will be considered also normal. Symmetrical bow tie with skewed radial axis, like there is deviation of the radial axis. This can be sometimes suspicious. Here, asymmetrical bow tie. This is suspicious for keratoconus with the inferior steepening. Asymmetrical bow tie with inferior steepening is suspicious for keratoconus. Asymmetrical bow tie with superior steepening, unlikely to be keratoconus. This is more likely to be scar. Asymmetrical bow tie with inferior steepening and skewed radial axis, this is very, very suspicious of keratoconus. So if we want to summarize what are the suspicious patterns of keratoconus, it will be D, it will be H, it will be J, and a little bit of G. Okay. So this is what will be the first thing to interpret in the map, in the topographic map or in the curvature map, which will be the pattern. What will be the pattern of the map? The second thing is what's called inferior minus superior value. What is the inferior minus superior value? If we have here coordinate topography, such a curvature map, we can see that there is a symmetrical bow tie with more steep inferiorly. And these are the K readings above, and these are the K readings below. In inferior minus superior value, we take a horizontal line and vertical line and calculate the value of 5 K readings above and 5 K readings below. Some just do the difference between the highest and the lowest or in the vertical, but the correct thing is to just calculate the upper 5 and the corresponding lower 5 values, and to take the average or take the mean of the above values and lower values, and then do the math and do inferior values, the mean of the inferior values minus the mean of the superior values, to know what will be the resultant number, to check if there is difference between the values of the lower half of the cornea and the upper half of the cornea. And now we will know what are the suspicious values. This shouldn't confuse you with what is called the index of surface variance. Index of surface variance, this is one of the keratoconus indices. It's also called ISV, but this is ISV, but this is called inferior minus superior value. So what are the range, normal range? It should be the difference, it should be less than 0.5 diopter. This is normal. If it is between 0.5 to 1 diopter, then this is called asymmetrical bow tie. If it is between 1 to 1.5, there is inferior steepening. If between 1.5 to 3, this is called formofrost keratoconus or subclinical keratoconus. If it is more than 3, this is a frank keratoconus. Okay, so what is the RERSS? This is what's called the Randleman Ectasia Risk Score System. This is out of scope of this lecture. We will not go through it. But this is like a scoring for the grade of keratoconus or the grade of risk of refractive surgery. It is more of keratoconus, okay? Okay, so the third thing that we check for the topographic map or for the sagittal curvature map is what's called axis skewing. We heard this sentence. What is meant by axis skewing? You can see this is the lower segment of the bow tie, and this is the upper segment of the bow tie. Both of them should be at the same radial axis. But what happened here is that the upper segment is a little bit skewed or tilted. The upper segment should be completed or should have completed like that, but it is now completed like that. So there is an angle between the supposed axis and the actual axis. This axis or this displacement, if it is more than 20 degrees, this is considered suspicious for keratoconus. So to summarize, the topographic map is considered suspicious if there is a rule of two. First of all, the steepest decay reading is more than 45/2. The steepest decay reading is different in both eyes by 2. So one eye is like 47 and the other is 44. So the Kmax is different in between both eyes by more than 2. Inferior minus superior value more than 2. Axis skewing is more than 2. Okay, so remember this rule of 2 in the sagittal curvature map. So actually, this is a part from my Pentacam lecture. I have already a full Pentacam lecture. You may find it in the YouTube, but unfortunately, it is on Arabic only, not in English. But I'm just bringing you the main ideas and main things that are relevant to you for the exam. For the elevation maps, what is meant by elevation maps? Again, consider that this is the cornea. It is 2,000 or 12,000 microns. And surprisingly, the diameter of the Earth itself is 2,000 or 12,000 kilometers, or remember, or assume that you have the Earth is 2,000 kilometers. So you can just consider them like the same. We are here trying to mimic the cornea by the Earth. Of course, the Earth is not 2,000 or 12,000 kilometers, but this is just hypothesis. So what do I need to say, or what I am meaning to say? If you are considering a cornea like the Earth itself is not having a simple or single plane surface. Like the cornea or the Earth has a certain elevation or depression. Like it has mountains, it has hills which are elevated above the surface of the sea, and it also has depression which is below the surface of the sea. Like the sea, there are depressed areas or there are hills. So the hills are below the sea. So the same thing happens with the cornea. The cornea itself, it is not all surfaces of the cornea are elevated to the same degree, or they are all the points of the cornea, they don't have the same level. Some areas are elevated, some areas are depressed. So how can it measure this elevation or depression? This is based on what's called the reference sphere. The device will calculate the radius of curvature of each point of the cornea, and then like it will calculate all the radii of curvature and then take its mean, and then by the mean we have a mean radius of curvature. This mean radius of curvature, the device or the Pentacam use it to calculate a new sphere. This sphere is not present in the cornea. It is just a hypothetical sphere. It is just an imaginary sphere. This sphere is called the best fit sphere. Best fit sphere is different from one patient to other because it is calculated based on his cornea. And then the device will measure each point of the cornea against this hypothetical sphere. So if the device finds any area elevated above this best fit sphere, it will give it plus value and will give it like hot colors like yellowish or reddish or green or orange, like this, for example. So the cornea is steep in the center. That's why the central area of the cornea having more plus values and more hot color. And the peripheral or the periphery of the cornea is more flat. So it is depressed from the best fit sphere. That's why it is represented by this cold color or this blue color. This represents the the depression of the cornea in comparison to the best fit sphere. So the elevation maps usually takes the hourglass pattern. Like this is the normal. It takes like an hourglass pattern. So again, this reddish area are or orange area are elevated, and this greenish area and the bluish area are depressed. And when we have this tongue-like extension, this is suspicious. This is very suspicious for keratoconus. So what are the normal values and the abnormal values? We have two maps. We have the anterior elevation maps and the posterior elevation maps. Anterior elevation maps, you can see here that the best fit sphere is 7.5. And here is the anterior elevation maps. When you check the values of the central 4 millimeters, which are more concerning, if they are more than 15 microns, then this is considered suspicious for keratoconus. If in the posterior elevation maps, if it is more than 20 microns, then again, this is considered suspicious for keratoconus. So in keratoconus, the values of the posterior elevation maps will be always higher than the anterior elevation because the keratoconus starts usually from posterior, or mostly it starts posteriorly. So for patients, you can find changes in the posterior elevation maps even before the anterior elevation maps. Okay, so this is how we interpret the anterior elevation maps based on the values in the central 4 millimeters. So here you can find that the center, it is plus 28, plus 34, here plus 46, plus 65. So this is considered like keratoconus. Finally, the pachymetry map or the corneal thickness map, you interpret it in the form of here is it will represent the points of thickness. So this is like 522 micron thickness. This is 412 microns of the cornea, and this circle represents what's called thinnest location. This is what will be the most important to look at. This is the thinnest location of this cornea, and if it is less than 590, it was first 500, then 490, now 470 micron. So these are can be considered suspicious for keratoconus, but sometimes it can be just a normal thin cornea. So you can see the values in the center 4 millimeters and also check for these parameters. So pupil center, it will be, and this is the thickness. So it will show you the thickness of the cornea at the pupil center. Pachy-apex will show you the thickness of the cornea at the geometrical center of the cornea. Geometrical center, which will be the intersection of the y and x axis. So this will be the geometrical center of the cornea, and this the device will plot zero values. So this will be the zero values, and then the pupil center and the thinnest location will be considered shifted from the pachy-apex. So you can see that there is minus and the plus values, minus and the plus values. These are considered up and down shift from the thinnest location from the pachy-apex. And the thinnest location also will show minus 7.2 millimeter shift in the horizontal diameter or in the horizontal meridian of the thinnest location. So it will be shifted temporally like that, while the plus will be shifted nasally. And the Y, there is no shift in the vertical meridian. So when should we consider the patient as suspicious for keratoconus? When there is lower temporal displacement of the thinnest location in the central 4 millimeters with thin cornea in the central 4 millimeters. Okay, so to summarize what we are going to check for the refractive map or for the refractive 4 maps, first of all, check what's called QS or quality specification. It should be okay. Sometimes it can show errors. And then check the K1 and the K2 to know what is the curvature, the values of the K readings for this patient. It will be the highest K and the lowest K. And also check what's called Kmax, which will be, doesn't have to be the same like K1, K2, but it can be higher. So this will be the highest point elevated in the cornea or the highest curved point in the cornea. This shouldn't increase more than 47.2. Check the sagittal curvature map or the front, the sagittal curvature map for the presence of what? For the pattern where there is inferior hotspot or irregular asymmetrical bow tie. Check for the inferior minus superior value if it is more than 2. Check the axis skewing, which is especially axis skewing should be more significant with higher refractive error rather than a smaller refractive error. So this should also be should be checked. So check again the Kmax, the inferior minus superior value, check the skewing, check the difference between the Kmax from the other eye shouldn't exceed more than 2. So check now the thinnest location. Thinnest location also check the number in the center 4 millimeter and check the displacement in the X and Y axis, and it should, if it is more than 0.5, it is considered suspicious for keratoconus. Check also for the Paki apex. There shouldn't be a large difference more than 15 or 20 microns between it and the thinnest location. Corneal thickness map showing any ectasia or thinning of the cornea. Anterior elevation maps and posterior elevation maps. For anterior elevation, the values in the central 4 millimeters shouldn't exceed 15 micron elevation, and the values in the central 4 millimeters shouldn't exceed 20 microns. Some patterns that can be presented to you in the exam, they can show you this topographic map. There is no astigmatism here. This is patient usually with a spherical error. And you can see that you can even interpret that from the values. You can see that the K readings are 42.7 to 41.7. There is like one diopter, or this is the highest K. It is, yeah, it is just a little bit of one diopter. Maybe it's very, very minimal astigmatism. For this patient, you can see that the K readings is 46.6 and 41.9. So there is like 5 diopters astigmatism, and this manifests by this symmetrical regular bow tie. This patient has vertical with the rule astigmatism. So how is this different from patients with keratoconus? You can see this is the patient with cone. This patient has an inferior hotspot. This patient has also keratoconus, more advanced keratoconus. So this can also be asked in the exam. Another also topographic map was asked before in the clinical ISO exams is the post-myopic laser. Post-myopic laser, let me draw you, and this will be the last slide, don't worry, we almost finished. So the cornea is flat in the periphery, steep in the center, and flat in the periphery again. In myopic laser, or if we want to correct the myopia, we want to decrease the patient's refractive error. So the laser will hit the center. This is for the myopia. So the patient has what's called prolate cornea. Prolate cornea is meaning that the center is steep and the periphery is flat. After the laser, the patient will have his cornea like that. That the center will be less curved than the periphery, and in this case we call it oblate. So this is the prolate, which has the center more curved than the periphery. Oblate, meaning that the center is less curved than the periphery. Okay. This will be the reverse for hyperopic laser. For hyperopic laser, we want to increase the patient's refractive error. So if this patient has hyperopia, we do the laser in the periphery for hyperopia. This laser in the periphery will cause more flattening of the periphery, leading to that the center will bulge more, causing more steepness of the center. Okay, so back to this case, this patient with post-myopic laser. So we did laser in the center, and this laser in the center will cause a flattening of the cornea in the center. So this will result in that the center of the cornea will be more in the cold color, like more bluish, more greenish, and the periphery of the cornea here is more steep. So when the exam presents you a picture like that and asks you what did this patient suffer from, don't say it is keratoconus. In the keratoconus, the center is steep, but it is just a post-myopic laser ablation. This patient had undergone a myopic laser ablation. Okay, so that's it for today. Thank you. Did you enjoy the lecture? Any questions? Okay, thank you very much for your attention. The next lecture will discuss MCQs for the lens and the cataract and the cornea. So try to be prepared, solve as many MCQs as possible. Try to catch up what you missed if you didn't watch any lecture. And we will meet again the next Monday so that we will solve the MCQs. So I think that we are almost finished half of the course. So I hope that you are not lagging in your study and you are not accumulating lots of study behind. Please try to keep up with the pace of the course so that you don't you don't run out of time before the exam. Okay, thank you very much for attention and see you next time.